Good morning, doctors. Today we are on the 8th day of reading Oxford Handbook of General Practice and we are at page number 251 today. Let us start reading. Aortic stenosis causes congenital, bicuspid valve, hypertrophic, rheumatic fever, degenerative calcification, cardiomyopathy. Presentation is symptom angina, breathlessness, syncope, funny turns, dizziness, sudden death. Signs: small volume pulse, low pulse pressure, difference between the systolic and diastolic is low, ejection systolic murmur loudest in the aortic area which radiates to the carotids and the apex. Management: echo is diagnostic and gives an estimate of the gradient across the valve and thus the severity of the condition. Refer to cardiology. Surgery: valve replacement or transcutaneous valvoplasty is considered for those with a syncope or with systolic gradient across the wall more than 50 millimeters of Hg. So this is the criteria for considering surgery. Avoid treatment with ACE inhibitors in aortic stenosis. It will cause hypotension. Aortic regurgitation causes congenital or VSD. Congenital cases with VSD, aortic dissection, syphilis, bicuspid aortic valve, endocarditis, Marfan's or Ehlers-Danlos syndrome, rheumatic fever, cardiomyopathy. Presentation of aortic regurgitation. Symptoms: dyspnea and palpitations, extrasystoles will be there. Signs: prominent pulse, a water hammer pulse, wide pulse pressure, visible neck pulsation or Corrigan sign, head nodding in time with pulse, Demasset sign, visible capillary pulsations in the nail bed, Quincke's sign, displaced apex beat, high pitched early diastolic murmur easily missed. Management: confirm with echo. Refer to cardiology for consideration of surgery. Right heart valve disease. Echo is diagnostic, always requires specialist management. The right heart valve diseases are tricuspid stenosis. Mitral valve disease coexists with tricuspid stenosis. Causes are rheumatic fever, murmur of tricuspid stenosis is early diastolic murmur, left sternal edge in inspiration. Treatment is with diuretics plus or minus surgery. Valvotomy or replacement. Tricuspid regurgitation. Causes are right ventricular enlargement, endocarditis, IV drug misusers, carcinoid, rheumatic fever, congenital. Presence with edema, breathlessness and pulsatile hepatomegaly plus or minus jaundice. Ascites, pansystolic murmur, loudest at the left sternal edge. Treatment is with diuretics, vasodilators, plus or minus surgery, valve replacement or annuloplasty. See, in right heart diseases, tricuspid regurgitation, has a pansystolic murmur. Pulmonary stenosis causes congenital like Fallet's tetralogy, rheumatic cause and carcinoid. So carcinoid can cause either tricuspid regurgitation or pulmonary stenosis. Murmur. Murmur of pulmonary stenosis is an ejection murmur, right? Ejection systolic murmur. Loudest to the left of the upper sternum, radiating to the left shoulder. ECG. Right ventricular hypertrophy will be there in pulmonary stenosis. Chest X-ray, dilated pulmonary arteries. Treatment, if needed, is with pulmonary valvotomy. Pulmonary regurgitation. Due to pulmonary hypertension, murmur is a decrescendo early diastolic murmur at the left sternal edge. Women planning pregnancy who have a known valvular disease require review for specialist advice. Other structural abnormalities of the heart. Coarctation of the aorta. Localized narrowing of the descending aorta, usually distal to the origin of the left subclavian artery. Presentation is there is heart failure Either they present with heart failure, high BP, murmur heard incidentally, ejection systolic murmur over the left side of the chest radiating to the back, lack of femoral pulses or radiofemoral delay. Rarely, presentation is with a complication, example, a subarachnoid hemorrhage or endocarditis. Chest X-ray, prominent left ventricle, ECG, left ventricular hypertrophy. Management. Refer to cardiology. Surgery to remove the narrowed portion of the aorta is usually indicated. Atrial septal defect. A hole connects the two atria. The holes high in the septum, that is ostium secundum type, are most common, 2 in 1000 live births. Holes lower in the septum, that is ostium primum type ASD, are associated with AV valve abnormalities. Okay, blood flow from the left to right through the shunt, and the right heart takes the burden because left atrial pressure is more than right atrial pressure, so blood flows from the left to right. Presentation. Ostium secundum defects. Symptoms are rare in infancy and uncommon in childhood. If detected in these groups, presents as a murmur, a systolic murmur, loudest in the second in left interspace. Found incidentally with breathlessness or tiredness or exertion or recurrent chest infections. Presentation is usually in the third or fourth decade of life with heart failure, pulmonary hypertension, or atrial arrhythmias. Ostium primum defects. Heart failure commonly develops in infancy, childhood, and severe pulmonary hypertension is present, plus or minus. In addition to the ASD murmur, there may be a pansystolic murmur signifying either mitral or tricuspid valve regurgitation. See, ostium primum defect is there is a hole in the septum in the lower portion which is adjacent to the both the AV valves. So there will be an associated AV valve disease, that is mitral or tricuspid valve diseases. Investigation. Chest X-ray. Cardiomegaly with a prominent right atrium, plus or minus pulmonary artery, plus or minus pulmonary plethora. ECG. There will be a right axis deviation in ostium secundum defects or left axis deviation in ostium primum defects. Right ventricular hypertrophy plus or minus right bundle branch block is present. Echo. Diagnostic. Management. Refer to cardiology. Cardiac surgery close to the defect is usually indicated. Ventricular septal defect. A hole connects both the ventricles. Blood flow is initially from left to right through the hole. May be congenital, 2 in 1000 live births, or acquired, usually septal rupture post MI. Acquired VSD. Suspect if new pansystolic murmur plus or minus heart failure develop after an MI. Investigate as per congenital VSD. Refer to cardiology. Speed of referral will depend on the state of the patient for advice on further management. Congenital VSD. If it is a small congenital VSD or Maladi D. Roger, normally asymptomatic. A thrill may be palpable at lower left sternal border. A harsh pansystolic murmur. Small holes give loud murmurs. Chest X-ray and ECG will be normal and diagnosis is confirmed on echo. Refer to cardiology. Moderate VSD. Symptoms usually appear in the infancy. Breathlessness on feeding or crying. Failure to thrive. Recurrent chest infections. As the child gets older, symptoms improve. Relative size of the defect will decrease. On examination, there may be a cardiomegaly. A thrill is palpable at the left sternal edge and a pansystolic murmur is heard. Chest X-ray shows cardiomegaly plus or minus prominent pulmonary arteries and pulmonary plethora. See why there will be prominent pulmonary arteries and pulmonary plethora in these septal defects is from the left ventricle or the left atrium where the pressures are high, the flow is towards the right. So right side circulation is increased. When right circulation is increased, there is more blood flow to the lungs and to the pulmonary arteries. That is why they will become prominent. Diagnosis is confirmed on echo and refer to cardiology. Large BSTs. Presence with a heart failure at 3 months of age, though there may be symptoms of breathlessness on feeding, crying prior to then. On examination, the baby is obviously unwell, underweight, breathless, pulmonary edema is present, plus or minus cyanosis, a large heart, thrill over the left sternal edge, plus parasternal heave or murmur. Not often pansystolic due to high right ventricular pressure. Admit to pediatrics, medical treatment plus or minus surgery is always required. See, in a large BSD, what happens? There is a heavy flow. Initially, the left ventricular pressure will be high. There will be a heavy flow towards the right ventricle because there is a big defect. And once the right ventricle is received more volume of blood, it will enlarge. It will become hypertrophied. In that case, the pressure will equalize. And then what happens? There will be a cyanosis because in either side there will be mixed blood that is flowing through the left ventricle. There will be a reversal of circulation from right ventricle to left again. So that is why there will be cyanosis. Often not, that's why there will be a thrill over the left sternal edge plus a parasternal heave and murmur, which is not pansystolic due to high right ventricular pressures. Admit to pediatrics. Medical management and surgery is always required in a large VSD. It presents early. If it's a large VSD, it presents within 3 months of age. Marfan syndrome, autosomal dominant connective tissue disease causing abnormalities of fibrillin, a glycoprotein in elastic fibers. Features include arachnodactylity, long spidery fingers, high arched palate, arm span is more than the height, lens dislocation, plus or minus unstable iris, aortic dilatation. Beta blockers appears to slow the aortic dilatation. Aortic incompetency may occur in pregnancy. Aortic dissection may cause sudden death. Echo screening may be helpful for affected individuals. If suspected, refer to cardiology plus genetics. There is currently no antenatal screening test available for Marfan syndrome. Other congenital heart diseases, page 858. Next is aneurysms. The atrial aneurysm forms when a 50% increase in normal diameter of the vessel. Aneurysm may affect any medium or large artery, aorta or iliac arteries, more than popliteal artery, more than femoral artery, more than carotid artery. So family history of aneurysm is a risk factor. Causes. Atheroma is the most common cause of an aneurysm. Injury, infection, example endocarditis, syphilis, mycotic aneurysms. Abdominal aortic aneurysm. Prevalence is 4% in men aged 65 to 74 years. Acute rupture of an aortic aneurysm, abdominal aortic aneurysm in the community has 90% mortality, accounting for 2% of deaths in males aged more than 65. Elective surgical repair has 5 to 7% mortality. Risk factors. Smoking is a risk factor for aortic aneurysm. In high BP, family history, risk is increased 4 to 10% if there is an affected first degree relative with aortic aneurysm. Factors predisposing to rupture of aortic aneurysm. The diameter is the highest risk factor. Risk with increased diameter, fast rate of expansion, COPD, smoking, increased diastolic BP, family history, inflammation within the aneurysm wall, thrombus-free surface area of the aneurysm sac. So the higher the thrombus-free surface area, the more the risk for rupture. Presentation, often discovered as an incidental finding on abdominal examination. X-ray, calcification of an aneurysm wall in 50% of the cases, or ultrasound scan, 75% symptomatic at diagnosis. Otherwise, presents with local symptoms, vague abdominal or back pain, distal symptoms, embolization or acute ischemia of a limb, multiple infarcts, example of the toes, with good peripheral pulses suggest an aneurysm proximally. Collapse due to rupture, hypovolemic shock, plus or minus pulsatile abdominal mass, plus or minus abdominal or back pain. So this is a collapsed rupture of aortic aneurysm. Investigation. Ultrasound confirms the diagnosis, diameter, the site, the extent. Screening. In UK, men aged 65 years are offered an aneurysm screening with single abdominal ultrasound. Men more than 65 can self-refer. Screening decreases the death from aortic aneurysm by 44% over 4 years. Possible screening results are given in figure 9.4. We will see how we will manage that. Management of abdominal aortic aneurysm. Acute rupture, elective surgery. Refer if the risk of rupture more than the risk of elective repair. The greater the diameter, the more the risk. Risk 5.5 centimeters is equal to 10% 1-year rupture rate, 10 centimeter diameter, more than 75% 1-year rupture rate. Aortic aneurysms, abdominal aortic aneurysms more than 5.5 centimeters are routinely repaired except if factors of high risk of surgery are there and there is no survival benefit from treating smaller aneurysms. Refer urgently if symptomatic, may indicate rapid expansion or inflammation, both risk factors for rupture. Ultrasound surveillance. Patients with an aortic aneurysm less than 5.5 cm diameter are screened at least annually. Routine repair takes place when and if the aneurysm expands to more than 5.5 centimeters, and 3 in 5 eventually warrant surgery. Inflammatory aneurysms. Characterized by inflammatory infiltrate in the aneurysm wall, may be adherent to the surrounding structures. Presentation is with fever, malaise, and abdominal pain associated with increased mortality at operation. So this is a flowchart for aneurysm. A single abdominal ultrasound screened aged 65 years. If it is normal, aortic diameter less than 3 centimeters, no further screening is needed. If there is a small aneurysm, aortic diameter 3 to 4.4 centimeters, offer further ultrasound in 1 year. If it is a small aneurysm, aortic diameter 4.5 to 5.5 centimeters, offer further ultrasound in 3 months only. And advice on CVD risk management. If it's a large aneurysm more than 5.5 centimeters, refer to vascular surgery. Thoracoabdominal aneurysm involves the thoracic and the abdominal aorta, including the origin of the visceral and renal arteries. Surgery is more complex and carries high risk of mortality. Dissecting thoracic aneurysm. We'll see in page 1060. Popliteal aneurysm. 80% of peripheral aneurysms. Most are more than 2 centimeters in diameter. 50% are bilateral. Associated with AA. Presents with acute below knee ischemia secondary to an aneurysm thrombus or an embolization. Popliteal pulses are pronounced. Diagnosis is confirmed on ultrasound. Management. Acute ischemia. In case of acute peripheral limb ischemia, the management is given in 1108. Elective surgery, popliteal bypass. When an aneurysm is more than 2.5 centimeters in diameter in the popliteal artery, you do a bypass. Femoral artery aneurysm. Presentation. Local pressure symptoms, thrombosis or distal embolization. Surgical treatment is bypass surgery. Carotid aneurysm. Rare. Presents with a pulsatile lateral neck swelling, plus or minus carotid territory TIS. Rarely can rupture. Refer for a vascular surgery for surgical treatment. Carotid body tumor. Slow growing tumor arising in the carotid body at the carotid bifurcation. Presents with a slowly enlarging mass which transmits carotid pulsation. Refer to vascular surgery for angiographic confirmation of diagnosis and treatment with surgical excision. If untreated, becomes locally invasive and may eventually metastasize. Cerebral artery aneurysm. 534. Next topic is page number 256, chronic peripheral ischemia. Peripheral vascular disease, normally atherosclerotic, commonly affects the arteries supplying the legs. Prevalence: 20% patients aged more than 60 years have a peripheral artery disease. Assess for presence of PAD. If symptoms suggestive of PAD or diabetes, non-healing wounds on the legs or feet or unexplained leg pain or being considered for interventions to the leg or foot, need to use compression hoisery. Natural history. Mostly remain stable. A minority to 20% over 10 years progress from intermittent claudication to critical limb ischemia. Management of CVD risk factors is essential. Intermittent claudication. Restriction of blood flow causes pain on walking. Risk factors are males more than females, smoking, obesity, high BP, hyperlipidemia, diabetes, physical inactivity, hypercoagulable states, and postmenopausal women. Presentation: present with muscular cramp-like pain in the calf, thigh, or buttock on walking that is rapidly relieved on resting. Their leg is cool and white with atrophic skin changes and absent pulses. Disease of the superficial femoral artery. Absent popliteal and foot pulses causes calf claudication. Disease of the aorta or the iliac artery. Weak or absent femoral pulse plus femoral bruit causes calf, thigh or buttock claudication. Differential diagnosis. Nerve root compression. Example: Sciatica or spinal stenosis, usually bilateral pain which occurs after prolonged standing as well as exercise, not rapidly relieved by rest. Investigations. In case of peripheral artery disease are full blood count, urea electrolytes, creatinine, EGFR. Peripheral vascular disease is associated with renal artery stenosis. That's why we are doing a full kidney profile. HbA1c and lipids. Ankle brachial systolic pressure index. So this is ankle brachial pressure index. This will tell you whether it is critical limb ischemia. Good history you have to take, and ABPI less than 95.95 confirms the diagnosis of peripheral arterial disease. So history of intermittent claudication plus ABPI less than 0.95 confirms diagnosis of peripheral arterial disease. Do not exclude peripheral arterial disease in people with diabetes based on normal or increased ABPI. So duplex ultrasound, excuse me, usually used to determine the site of the disease, may only be available via secondary care referral. Management. Exercise. Offer a supervised exercise program, ideally 2 hours per week for 3 months to all patients. Encourage to exercise to the point of maximal pain. Decrease the risk factors. Patients with a claudication have 3 times increased risk of death from MI or stroke. Advise to stop smoking, moderate the alcohol intake and lose weight. Ensure optimum treatment of raised BP, lipids and diabetes. Antiplatelet agents. Treat all patients with aspirin 75 milligrams OD or clopidogrel or OD if aspirin intolerant. But I think as per the recent NICE guidelines we were reading yesterday, you have to use you have to prefer clopidogrel over aspirin and then statin for peripheral artery disease. Foot care. Regular chiropody. Refer to vascular surgery. When do you have to refer to vascular surgery in PAD? In emergency. Critical limb ischemia. So emergency or urgent admission. Uncertainty about the diagnosis. Routine admission. Routine referral. Severe symptoms. Soon. Know better after exercise training. Routine referral. Location of pulses of the lower limbs. Femoral pulse. Where do you check it? Below the inguinal ligament. 1/3 of the way from the pubic tubercle. Up from the pubic tubercle. Popliteal. With knee flexed at right angles, palpate deep in the midline. Posterior tibial pulse. 1 centimeter behind the medial malleolus. Dorsalis pedis is variable on the dorsum of the foot, just lateral to the tendons of the big toe. Many healthy people who have only 1 foot pulse. Critical limb ischemia. Presentation. Deteriorating claudication and nocturnal rest pain, usually just after fallen asleep. Hanging the foot out of the bed improves the pain. Ulceration or gangrene results from minor trauma. Examination. What do you have to look for? Atrophic skin changes. So whenever there is peripheral arterial disease or chronic arterial insufficiency of the lower limbs, you will see some skin changes. Pallor, cool to touch, hairless and shiny. So on lowering the legs turns dusky blue-red color. On elevation there will be pallor and venous scuttering. Ulceration. Check under the heel and between the toes. There will be ulcers under the heel and in between the toes. Swelling suggests that the patient is sleeping in a chair to avoid rest pain or rarely pain from deep infection. Absent foot pulses, if present, consider an alternative diagnosis. ABPI less than 0.5 is a critical limb ischemia. Arterial calcification can result in falsely high readings. Management. Analgesia often requires an opioid. Refer for urgent vascular surgical assessment. Diabetic foot. Specialist management of peripheral arterial disease. Angiography. To assess the extent and position of disease, percutaneous transluminal angioplasty or stenting. PTCA, this is transluminal angioplasty and stenting for peripheral arterial disease. Most suitable for short occlusions or stenosis of the iliac or superficial femoral vessels. So for the big vessels. 1 year patency rate is 80 to 90%. Surgery. Most suitable for longer occlusions or multiple stenosis. When it goes to surgery, it is bypass surgery. Bifemoral bypass grafts. have 5 years patency life more than 90%. Femoropopliteal bypass grafting gives 5-year patency less than 70%. Aspirin decreases the risk of reocclusion. Amputation is the last option. Drug treatment for intermittent claudication. NAF, naftidrofuryl oxalate increases the walking distance but is unclear whether it influences the outcome. Consider only if supervised exercise program has not led to improvement and the person does not want or is unsuitable for angioplasty or bypass surgery. Reassess after 3 to 6 months. Discontinue if there is no improvement with naftidrofuryl. Acute limb ischemia. Page number 258. Varicose veins. Tortuous, twisted or lented veins. Prevalence is 17 to 31%. Male is more common than females, 5 to 4 ratio. The vein wall is inherently weak, leading to dilatation and separation of the wall cusp, so they become incompetent. Blood flows backward from the deep to superficial system, causing back pressure, further dilatation. Most varicose veins are primary. Risk factors are age, parity, occupations requiring long lot of standing, obesity, women only. Secondary causes are when there was a previous DVT, pelvic tumor, pregnancy or AV fistula. So when the deep veins are blocked, the blood flows through the superficial veins. So that causes varicosities. Pelvic tumor, there is a back pressure, pregnancy and AV fistula. Types of varicosities: truncal varicosities. Trunk varicosities of the long or short saphenous vein of the branches may be symptomatic. Reticular, usually asymptomatic, dilated tortuous subcutaneous veins not belonging to the main branches or the long or short saphenous veins. Telangiectasia, intradermal venules less than 1 mm, spider veins, thread veins, star bursts, matted veins, unsightly but otherwise asymptomatic. Presentation: consider why is the patient consulting now? Yes, patients are often worried about the appearance of varicose veins or prognosis if left untreated but have no other symptoms. 1 in 3 consultations. Symptoms: heaviness, tension, aching, worse on standing and in the evening, improved by elevating the leg and support stockings, itching. Complications: PMH, previous surgery or injection of the varicose veins, pregnancy, past history of DVT or thrombophlebitis, CHC or HRT. So, combined hormonal contraceptives or hormone replacement therapy. Uh, Family history, varicose veins or DVT. Examination. Abdominal examination to exclude the secondary causes. Veins. With the patient standing, inspect the distribution of the veins and any secondary skin stages, patterns of distribution. Long saphenous vein distribution is the thigh and the medial aspect of the calf. Short saphenous vein distribution below the knee on the posterior and lateral aspects of the calf. Management. Reassurance is all that is needed. If symptoms are troublesome, advise support stockings. Avoid standing for prolonged periods. If standing, not stand still. Walk regularly. Decrease the weight if obese. Any complications or symptoms, refer to vascular surgical assessment. In general, patients with purely cosmetic problems are not treated under the NHS. Check the ABPI to exclude a significant arterial disease before recommending compression hoisery. So, ankle brachial pressure index should be more than 0.8 when you are recommending compression stockings. Bleeding, varicose veins. Bleeding can be stemmed by raising the foot above the level of the heart and applying a compression. If the patient is fit for surgery, refer for surgical assessment. Once recovered from the bleed, advise a compression hoisery if ABPI is more than 0.8. So, whenever there is a varicosity, you have to check for peripheral arterial disease before advising any compression hoisery because that will again impair the arterial circulation. Complications: hemorrhage, varicose eczema. This is more common presentation. Skin pigmentation. Yes. Lipodermatosclerosis, fibrosis of the dermis and subcutis around the ankle resulting in firm induration. Thrombophlebitis, venous edema, venous ulceration. For more than 40% do not have visible varicose veins, but they have venous ulceration in particular points. Atrophy blanche, white lacy scars are present. CHC and HRT, combined hormonal contraceptives and hormone replacement therapy. Women with varicose veins taking CHC or HRT are not at increased risk of DVT but are at increased risk of thrombophlebitis. Saphena varix, dilatation with saphenous vein at its confluence with the femoral vein, which transmits a cough impulse, may have a bluish tinge and disappears on lying down. A cause of a lump in the groin, action only if symptomatic. Thrombophlebitis presents as severe pain or erythema pigmentation over the hardening of the vein. Thrombophlebitis in varicose veins results from stasis. Consider underlying malignancy or thrombophilia if thrombophlebitis occurs in normal veins or there is recurrent thrombophlebitis in the varicose veins. Management. There is no indication for antibiotics in thrombophlebitis. Scrape bandage to compress the vein and minimize propagation of the thrombus. If ABPI is more than 0.8, then only compression bandages. Analgesia, preferably NSAID, ice pack and elevation, low dose aspirin 75 to 150 milligrams prophylactically. If phlebitis extends up along the saphenous vein, towards the saphenofemoral junction, refer urgent duplex scanning. Saphenofemoral ligation may be indicated if the thrombus extends to the femoral vein. Follow-up. If the patient is fit for surgery, refer for surgical assessment as thrombophlebitis tends to recur if the underlying venous abnormality is not corrected. History of thrombophlebitis is a relative contraindication to CHC, combined hormonal contraceptives. Evidence regarding HRT is less clear. Thrombophlebitis migrans, recurrent thunder nodules affecting the veins throughout the body associated with carcinoma of the pancreas. So these are superficial vein thrombosis, that is called thrombophlebitis. Whereas in deep vein thrombosis, there is other management. In superficial vein thrombosis, you have to just give analgesia and then you have to check whether it is extending to the confluence of the saphenous vein and the femoral vein, and then you have to see if the thrombus is expanding and then you have to refer for surgical management. But however, deep vein thrombosis is a different issue. DVT may be proximal, involving the veins above the knee, or isolated to the calf veins. It may occur in the cerebral sinus and veins of the arms, the retina, and the mesentery. Incidence is 1 in 1,000 people. Risk factors of DVT are age more than 40, smoking, obesity, immobility, recent long distance travel, pregnancy, puerperium, CHC or hormone replacement therapy use, surgery, recent trauma, malignancy, heart failure, nephrotic syndrome is a pro-inflammatory procoagulant state, inflammatory bowel disease, PMH of the venous thromboembolism, inherited thrombophilic clotting disorders, other chronic illness. May comment in the comment section what is PMH. Central venous catheters are a common cause of upper limb DVT. Presentation. Unilateral leg pain, swelling or tenderness plus or minus fever, pitting edema, warmth, distended collateral superficial veins. Differential diagnosis is cellulitis, arthritis or muscle tear, ruptured Baker's cyst, superficial thrombophlebitis, chronic venous insufficiency, venous obstruction, post-thrombotic state, acute arterial ischemia, lymphedema, fracture, hypoproteinemia. Immediate action. Clinical diagnosis is unreliable. Less than 50% cases with clinically suspected DVT have diagnosis confirmed on diagnostic imaging. In most areas in UK, rapid access DVT assessment clinics operate. If there will be a delay in investigation to exclude the DVT, provide anticoagulation with the direct oral anticoagulant or low molecular weight heparin in the interim. So clinical prediction values, well score. There is a two-stage well score for diagnosing DVT. They are used to decide whether the patient falls into high or low probability group for DVT. If low probability of DVT, do a blood D-dimer first. If negative, DVT is excluded. If positive, assess the patient as a medium or high probability case. If medium or high probability case is there, compression ultrasound assessment is undertaken plus or minus D-dimer. If an ultrasound is negative and low probability or negative D-dimer, DVT is excluded. If ultrasound is positive, diagnosis of DVT is confirmed. If ultrasound is negative and a medium or high probability case, then positive D-dimer and a positive D-dimer, ultrasound is repeated after 1 week or the patient is assessed with a venography or CT or MRI. So we'll have a flow chart for that. We'll check that. D-dimer testing. D-dimer testing detects the degradation products of fresh venous thrombus. It may be available near the patient test result within 15 minutes. In some practices, do not delay referral to await result if near patient testing is not available. A normal D-dimer test result has high negative predictive value for making DVT unlikely. However, a raised D-dimer does not specific for venous thromboembolism. Other causes of raised D-dimer are malignancy, pregnancy, wound healing, recent trauma, inflammation, anticoagulants use, sepsis or liver impairment. Management of patients with confirmed DVT. Initial anticoagulation is an outpatient with either direct or oral anticoagulation, rivaroxaban or apixaban, or low molecular weight heparin followed by oral anticoagulation, usually warfarin. If anticoagulation with warfarin or low molecular weight heparin should be continued for at least 4 days and until INR is therapeutic range, that is INR 2.5, range 2 to 3 for less than 2 days. Oral anticoagulants. Risk of further thromboembolism should be decrease the risk of further thromboembolism and should be continued for 3 to 6 months after single DVT. Graduated elastic compression stockings should be worn for more than 2 years as they decrease the risk of post-thrombotic leg syndrome by 12 to 50%. So compression stockings only decrease the risk of post-thrombotic leg syndrome. If a patient has a DVT and there is no obvious cause, if less than 45 years, consider thrombophilia. If more than 45 years, consider an undiagnosed cancer. Okay. Management during pregnancy, 802. Complications of DVT. Pulmonary embolus. Without treatment, 20% of proximal DVT people develop pulmonary embolism. Post-thrombotic syndrome occurs after a DVT. It results in chronic venous hypertension causing limping, swelling, hyperpigmentation, dermatitis, ulcers, venous gangrene and lipodermatosclerosis. Recurrent venous thromboembolism. Patients with a history of DVT or pulmonary embolism have increased risk of recurrence of high risk recurrence in high risk situations like whenever they are having a trauma, surgery, immobility or pregnancy, there is high risk of again repeat DVT and should receive prophylaxis with heparin or oral anticoagulation in such situations. So 9.2 Wells diagnostic algorithm. Score 1 point if give 1 point each if it's an active cancer, they have an active cancer, ongoing treatment or treatment in the past 6 months or palliative care, if there was paralysis, paresis or recent plaster immobilization, recent bedridden for more than 3 days or major surgery in the past 12 weeks under GA or regional anesthesia, localized tenderness along the distribution of the deep venous system, that is back of the calf, there is a swelling of the entire leg, calf diameter of the affected leg measured 10 cm below the tibial tuberosity, more than 3 cm greater than the unaffected leg, pitting edema of the affected leg but not the unaffected leg, collateral superficial veins, non-varicose veins are there, and previous DVT is there. So 1 point each. Take away 2 points if an alternative diagnosis is as more likely than DVT is present, like cellulitis or any other alternative diagnosis. Then you take away 2 points. Interpretation. If the score is less than 2, DVT is unlikely. If the score is more than 2, DVT is likely. Further information. So this is the end of the chapter cardiovascular disease. We are into the next chapter, respiratory diseases. Respiratory medicine, page number 263. Breathlessness, dyspnea, sensation of shortness of breath, speed of onset helps the diagnosis of dyspnea. Try to quantify exercise tolerance, dressing, distance walked, and climbing stairs. Acute breathlessness. We'll see in 1068. Exertional dyspnea. Breathlessness with exercise. Causes are same as that of dyspnea generally. The New York Heart Association classifies the severity and functional limitations in patients with heart failure. NIHA classification for heart failure: Class 1 normal, no limitations; Class 2 slight limitation of ordinary activity; Class 3 marked limitation during less than ordinary activity, example walking short distances; Class 4 inability to do any activity, symptoms present at rest. Orthopnea: dyspnea on lying flat and relieved up by sitting, associated with left heart dysfunction, example left ventricular failure. Paroxysmal nocturnal dyspnea: acute form of dyspnea that causes the patient to wake up from the sleep. The patient is forced to sit upright or stand out of bed for relief, associated with pulmonary edema. PND is associated with pulmonary edema. Combined chest pain and dyspnea. Consider, if a patient is having chest pain as well as dyspnea, you consider first, is it an MI? Is it pericarditis? Is it a dissecting aneurysm? Pulmonary embolism? Esophageal pain? Musculoskeletal pain? Chest infection? Pulmonary malignancy? Refer any patient with symptoms or signs of superior vena cava obstruction like acute breathlessness, headache, worse on stooping, swelling of the face or neck with fixed elevation of the JVP for immediate medical or oncological assessment. Offer urgent chest X-ray if more than 40 years of age or more than or more than two of is present, or if smoker, ex-smoker, history of asbestos exposure and more than one. What is this more than two and more than one? Okay, more than two of the following symptoms, unexplained symptoms are present, or more than one of the following symptoms are present. That's what they meant. Like cough, the patient is having cough, fatigue, shortness of breath, chest pain, weight loss, appetite loss. So, when do you offer an urgent chest X-ray? If the patient is over 40 years and two of the following unexplained symptoms are present: cough, fatigue, shortness of breath, chest pain, weight loss, and appetite loss, which are unexplained by anything else, then you refer for a chest X-ray. Or if the patient is an ex-smoker or a history of asbestos exposure, then if there is he is more than 40 and any one of these symptoms are present, you for an urgent chest X-ray. Respiratory rate. Normal values according to the age. This is the normal respiratory rate. Less than 1 year is 30 to 40 breaths per minute. 1 to 2 years is 25 to 35. 2 to 5 years is 25 to 30. 5 to 12 years is 20 to 25 breaths. And more than 12 years is 15 to 20 breaths per minute. This is the normal respiratory rate. When there is an increased respiratory rate, consider lung disease, pneumonia or asthma, heart disease, left ventricular failure, metabolic diseases like ketoacidosis, drugs like salicylate overdose, psychiatric causes like hyperventilation. If there is decreased respiratory rate, consider CNS disease like CVA or drugs like opioid use. Pneumothorax, page 1070. Hyperventilation may be a fast, more than 20 breaths per minute, or deep tidal volume is increased. If inappropriate, results in palpitations, dizziness, faintness, tinnitus, chest pains, perioral and peripheral tingling due to decreased plasma calcium. Causes of dyspnea. Cardiac disease. Cardiac causes of dyspnea, acute dyspnea are acute left ventricular failure, arrhythmias, acute MI, aortic dissection or tamponade. Subacute causes: arrhythmias, subacute bacterial endocarditis or pericarditis. Chronic causes of dyspnea of cardiac disease: CCF, valvular disease, mitral stenosis, congenital heart diseases. Lung diseases causing dyspnea: acute attack of asthma, COPD exacerbation, upper airway obstruction, pneumonia, acute pneumonitis, example due to inhaling a toxic gas, pulmonary embolus, or pneumothorax. If it is subacute onset of dyspnea, asthma, COPD exacerbation, pneumonia, pleural effusion, and lobar collapse. Asthma, chronic onset of dyspnea, asthma, COPD, cystic fibrosis, interstitial lung disease, occupational lung disease, mesothelioma, or lung cancer. Other causes: Hyperventilation, foreign body inhalation, Guillain-Barré syndrome can cause acute onset of dyspnea, altitude sickness, ketoacidosis, polio, musculoskeletal pain, or esophageal pain can cause acute onset dyspnea. Whereas subacute onset aspirin poisoning, myasthenia gravis, thyrotoxicosis, superior vena cava obstruction, these are subacute causes, other causes of dyspnea. Kyphoscoliosis, obesity, anemia, neuromuscular disorders, neuromuscular weakness like motor neuron disease or multiple sclerosis can cause slow onset, chronic onset dyspnea. Causes include causes of hyperventilation include anxiety. Most common cause early pulmonary edema, pulmonary embolism, hyperthyroidism, fever, lymphangitis, weakness of the respiratory muscles. Kusumal's respiration is a deep sighing type of breathing. Deep sighing breathing that is principally seen in metabolic acidosis, example diabetic ketoacidosis and uremia. Neurogenic hyperventilation. When there is a stroke, tumor or CNS infection, then there is neurogenic hyperventilation. Hypoventilation. Abnormally decreased pulmonary ventilation, respiration may be too slow or tidal volume is too low. Causes include respiratory depression like opioid analgesia, anoxia or trauma, neurological diseases like Guillain-Barré syndrome, polio, motor neuron disease or bulbia, lung diseases like pneumonia, collapse, pneumothorax, pleural effusion, respiratory muscle diseases like myasthenia gravis, dermatomyositis, limited chest movement like in kyphoscoliosis. So these are the causes of dyspnea due to hypoventilation. Cheyne-Stokes respiration. Cheyne-Stokes breathing. Breathing becomes progressively deeper and then shallower. Episodic apnea in cycles. Causes are brainstem lesions, compression due to compression either due to stroke or increased ICP, chronic pulmonary edema, poor cardiac output. It is enhanced by narcotics. Cough. Cough is a reaction to irritation anywhere in the pharynx to the lungs. Acute cough less than 3 weeks. Causes are upper respiratory tract infection, croup, tracheitis, acute bronchitis, pneumonia, productive or loose cough, acute exacerbation of normally well-controlled asthma, inhaled foreign body especially in children, reserved chest X-ray for patient with marked focal chest signs of inhalation of a foreign body or lung cancer is suspected. So management, treat the cause where possible. Steam inhalation often eases the symptoms temporarily, review if not clearing. Reasons to prescribe antibiotics immediately when there is a cough. Investigate further or give antibiotics, example amoxicillin 500 mg TDS, clarithromycin 500 mg BD or chloroxycillin 100 mg OD immediately if the patient is systemically very unwell or has symptoms or signs suggestive of serious illness or complications, example pneumonia. When there is a pneumonia, you need to give antibiotics. At high risk of serious complication because of pre-existing comorbidity like has a significant heart, lung, liver, renal or neuromuscular disease or immune suppression. So then you give antibiotics. Cystic fibrosis, young children who were born prematurely, you need to give antibiotics. Is aged more than 65 years with an acute cough and more than 2 of the following are present, or aged more than 80 years with an acute cough and more than 1 of the following is present. So he was previously hospitalized in the previous year, type 1 or type 2 diabetes, history of congestive heart failure, concurrent use of glucocorticoids. So then you need to give them antibiotics immediately. For 65 years old, 2 or more should be present, either diabetes or hospitalization or heart failure or oral glucocorticoids. Whereas in 80 above, only 1 of these should be present for starting an antibiotic immediately. Chronic cough, more than 3 weeks cough, either due to postnasal drip, post-viral cough, COPD or asthma, lung cancer, pertussis, tuberculosis, bronchiectasis, pulmonary edema, foreign body, vocal cord palsy, GORD, left ventricular failure, drug-induced ACE inhibitor, smoker's cough, earwax, psychogenic or idiopathic. Red flag signs is when there is either a weight loss, night sweats, fever, hemoptysis. Management. Often an urgent chest X-ray in those more than 40 years old if they have, yes, we have read about this, right? More than 40 years if they have 2 of the following like cough, fatigue, shortness of breath, weight loss, appetite loss, and more than one of the following if they were an ex-smoker and more than 40 years age, then offer a chest x-ray. If no cause is found on chest x-ray, refer them to the specialist. Sputum. Absolutely clear sputum is probably saliva. Smoking is a leading cause of excess sputum production. Look for black specks of inhaled carbon. Yellow-green sputum is due to cell debris, bronchial epithelium, neutrophils, eosinophils, and is not always infected. Bronchiectasis causes copious greenish sputum. Blood-stained sputum or hemoptysis always needs a full investigation. Pink froth suggests a pulmonary edema. Hemoptysis. Expectoration of blood and blood-stained sputum. Causes are infection. Infection is the most common cause of hemoptysis. Bronchitis, pneumonia, lung abscess or TB, violent coughing, bronchiectasis, lung cancer, pulmonary embolism. Blood is not mixed with sputum. Inhaled foreign body, iatrogenic due to anticoagulation or an endotracheal tube, trauma, cardiac causes of hemoptysis like acute left ventricular failure, mitral stenosis, blood dyscrasias or bleeding diathesis, idiopathic pulmonary hemosiderosis, bronchial adenoma, mycosis, aspergilloma, Goodpasture syndrome, collagen vascular disease, polyarteritis nodosa, granulomatosis with polyangiitis, PAN and GAP, and idiopathic. Differentiated from hematemesis or local bleeding from the nasopharynx or sinuses, melena may occur if enough blood is followed. Management always requires investigation to find out the cause of hemoptysis. Admit for an acute medical emergency if his patient is compromised by bleeding, that is, where is tachycardia, low BP or postural droop, or has symptoms or signs of requiring acute admission like a pulmonary embolism or an acute left ventricular failure. Refer for urgent chest physician assessment if age is more than 40 years with unexplained hemoptysis. So, if age is more than 40 years and there is an unexplained hemoptysis, you need to refer for a chest physician. Patients with a lung cancer who have massive hemoptysis and terminal event, consider treating with IV morphine or diamorphine and sedative, midazolam or rectal diazepam rather than admitting. So, whom you know. So, unexplained, you have to admit. He has an explained cause of hemoptysis. So, you have to give them treatment. Morphine, diamorphine, sedative, midazolam or rectal diazepam. Bronchiectasis. Consider the patients with persistent or recurrent chest infections. Permanently dilated bronchi acts as sumps of infected mucus. Causes are congenital cystic fibrosis or Cartagena syndrome, post-TB infection like TB, pertussis, measles or pneumonia. Others like bronchial obstruction or aspergillosis, hypogammaglobulinemia, gastric aspiration can cause bronchiectasis. Presentation. Mild causes. Usually asymptomatic with winter exacerbations consisting of fever, cough, pudendal sputum, pleuritic chest pain or dyspnea. More severe cases. Persistent cough and sputum, hemoptysis, clubbing, low-pitched inspiratory or expiratory crackles and wheeze. Investigations. You do a chest x-ray, sputum microscopy, culture sensitivity, spirometry, reversible airway obstruction is common. High resolution CT detects the disease in 97% of the cases. This is HRCT is diagnostic for bronchiectasis. Management. Refer to a respiratory physician. Treatment includes physiotherapy, yes, postural drainage of the sputum, antibiotics, bronchodilators, vaccination, influenza and pneumococcal vaccination, and rarely surgery. Chest signs. So we have seen the symptoms of chest respiratory disease. Signs. Signs associated with common chest pathology are given in table 10.2. Chest deformity, barrel chest. Anterior posterior diameter of the chest is high compared to the lateral diameter and expansion is reduced. Ribs move in a pump handle up and down motion associated with chronic inflation, that is asthma or COPD. PGN chest, pectus carinatum, prominent sternum and flat chest associated with a history of chronic childhood asthma or rickets. Funnel chest, pectus excavatum, the lower end of the sternum is depressed, often inherited or idiopathic and usually harmless. Kyphosis, there is increased forward spinal convexity, usually affecting the thoracic spine. Postural drooping, it could be postural because of drooping shoulders or round back is common, voluntarily correctable. Or structural kyphosis, cannot correct voluntarily. Causes are osteoporosis, Paget's disease, ankylosing spondylitis, Schliemann's disease may cause a restrictive ventilative defect and eventually respiratory failure. So this is a structural cause causing a respiratory problem. Scoliosis, so anything with the spine and decreases chest expansion. Harrison sulcus is a groove deformity of the lower ribs at the diaphragm attachment site, suggests a chronic childhood asthma or rickets. Harrison sulcus, either in rickets, childhood asthma, or rickets. Scars. There are many scars indicative of previous chest surgery. Chest expansion should be symmetrical and equal. If not, suspect a chest pathology. Consolidation, collapse, pneumothorax, effusion on the side of decreased movement. Vocal frequency or resonance. Increased transmission implies consolidation. Even widespread sounds are heard clearly with a stethoscope. Pectoriloquy. Decreased transmission implies something on the way blocking the transmission of sound. Consider air, pneumothorax, fluid effusion, pleural thickening or mesothelioma. So when there is decreased transmission implies there is something in the way blocking the transmission of sound. So consider either there is air like a pneumothorax or fluid effusion, pleural thickening or mesothelioma. That is decreased breath sounds are seen in these conditions. So we will stop here and we'll continue from page number 268 tomorrow. Thank you friends. Have a good day.